All right. Hello, folks, and welcome to our March edition of the Valuation Lab Chat Series with the Medical Industry Leadership Institute. Steve Renti here from the Carlson School and joined with Tom Gunderson, our Executive Residence and Fellow Chair. We are pleased to have with us a longtime colleague from the School of Public Health, the newly minted Division Chair of Health Policy Management, Jean Abraham, fabulous health economist who's been at the U for a bit. Jean has been doing a lot of research in many different areas, but one that's really an interesting one that we focused on recently, talking to some folks in DC, was price transparency. And a lot of that focused on the insurer side, but Jean's been doing research and publishing articles on the hospital side as well. So for those that are joining in, just a little bit of our customs here. We record the first 30 minutes of this, and it's on the record. And then at the half-hour point, we go off the record and go Q&A for other folks along the way. It's strictly conversational, so don't enjoy, basically. So, Tom, I'm going to hand the baton over to you, and then actually, well, let me introduce Jean first, and then I'll be. So Jean's awesome, actually. So Jean and I share the same dissertation advisor. We talked about this for a long time. Marty Gaynor from Carnegie Mellon. If you have issues with Jean and I, blame Marty and maybe other people along the way. Jean basically trained at Carnegie Mellon University in health economics and public policy analysis. She has become an endowed chair, the Wigmore chair, I believe, in the Division of Health Policy and Management at the University of Minnesota. She also has served as senior economist at the Council of Economic Advisors, actually at the end of the Bush II administration, beginning of Obama, and actually is one of the key people involved in the architecture of the original pieces of ACA and been very helpful for the state. And we're just thrilled to have you here.
Well,
Tom, thank you. Tom, I'll hand it over to you for first question.
Okay, so thanks, Steve, and welcome, Jean. Price transparency means different things to different people, but specifically what we're looking at is laws that were put in place and enacted, I believe, in January of 2021. If we could just make sure we're all on the same page, give us a little bit of history of where were we, where are we today, and then I'll let you and Steve kind of talk about where are we going tomorrow. But let's just start off with, I think Mark Twain said something along the lines of, let's get the facts straight first, and then we can distort them at our leisure. What are the facts of price transparency from a Washington standpoint?
Yeah, thanks, Tom. Well, of course, we want to kind of do some good table setting here to get going. And when we think about healthcare price transparency, I actually think back to about 20 years ago. At that time period in this country, we really were starting to have a conversation about our health system, about the quality of care, about the cost of care, and really thinking about how well or not well are we doing as a healthcare system. And so at that same time, we started to see what was called a consumer-driven healthcare movement, which was a big shift in how our insurance system was, the types of health plans that were being sold to employers and that many people with private insurance held. And as we started to move in those directions, there was a greater call for understanding the price of care, because consumers were in essence going to be paying more out of pocket. We wanted that idea of, if we have costs rising, we can try to address that by really, giving consumers incentives to shop for care. And so that came through benefit design. But in order to be successful at that, you need to have information on prices. And you need to have consumers being able to use that information when making decisions about where they were going to seek care. So that really dates way back into the early 2000s. And the version 1.0 of price transparency was pretty blunt. It was typically the prices that were available or made public often didn't correlate at all to the prices that people faced with insurance because of the difference between what is known as charges and what was actually a negotiated price between an insurer and a provider organization. So if we move forward in time, over that first decade of the 2000s, we had a lot of state initiatives to try to enhance price transparency alongside kind of quality and public reporting of quality of care. We get to 2010 in the ACA, and tucked in the ACA is about 2 paragraphs, which basically says that hospitals shall make publicly available their charges. Well, it turns out that for several years, nothing happened with this particular provision in the ACA. And then we started to see some rules happen that were, again, very low bar and not terribly well enforced. Fast forward to the Trump administration, where Steve was at working, and we have kind of the newest rule, the rule that became effective on January 1st, 2021 for hospitals, where it called for hospitals to produce publicly available files, 2 forms, the 5 standardized charges in machine readable form, plus a consumer shoppable data set for consumers to be able to access for common procedures and services that were more elective in nature. And so that went into effect in 2021. And now we are monitoring kind of hospitals' compliance with this new regulation, which is, again, a pretty big departure from what had been in the past. And similarly, we have health plans also subject to transparency reporting. They were delayed a little bit, but they are also on their way.
Thanks for that. So these are not the full retail price that's being reported. These are the actual, this is what we charge. This is kind of.
Yep. So the big departure, the big kind of, I think, pivot here is that not only do hospitals have to report kind of gross charges, which is what we think of as the charge master, plus what the discounted self-pay rate would be if you were uninsured. But they also have to produce their payer-specific negotiated rates. And that's the big point of controversy, because historically, that's always been very much protected from the part of hospitals and their payer organizations. And now that's going to be made public so we can all see just how much variation there is in what a hospital gets paid across different payers for the same service, as well as how much variation there is across hospitals in the same market. And that gets the dialogue going for why is this the case and how might this change the competitive landscape?
So are there examples anywhere in the country of anybody who's looked at this, whatever the data are in their own local area, and said, oh, look at this wide disparity, which we all know exists in healthcare anyhow, right? Here's this wide disparity, and something surprising happens, either the low guy raises his prices, or the low cost guy gets more business. Is there anything, is it too early for there actually to be repercussions from the?
Yeah, I think it's a little bit, so it's not too early to start documenting how much variation there is. And there's been an explosion of articles put out in the peer-reviewed literature documenting, orthopedic services or ophthalmology services, or, take your pick of specialty care, imaging, to really start looking at just how much variation exists in kind of orders of magnitude. I think that, the more interesting question is, what will be hospitals' strategic responses or insurers' strategic responses to this? And, what we hear anecdotally is that, of course, how a hospital responds is going to be a function of their relative position in the market. Are they priced low relative to their peers? And now, of course, that information can be known where it might not have been previously. We know that anecdotally, that firms are going back to insurers asking for better rates. So that's not going in the direction I think economists would prefer it to go if we're thinking about promoting competition. On the other hand, I think to be able to see anything kind of systematically, it's still a little bit early because we're still, compliance with reporting is only at about half of all hospitals at this point. That's some of the work that I've been doing with my colleagues in the School of Public Health, is that we've been tracking hospital compliance after the first year and then after the second year. And so we have a couple of studies looking at that.
Now, there's penalties for not reporting this, right? Has anybody had to pay a penalty?
Only 2 hospitals. So this is also a point. So obviously the one reason we wonder why hospitals have not complied, there could be a number of reasons for it, but obviously one has to do with the fact that CMS has not been as assertive in enforcing the compliance in terms of imposing penalties. They have been issuing warning letters. Some of it we have to think about the context of this. We're coming out of a pandemic. Hospitals are really facing pretty bad financial situations right now. And so they've not been as aggressive in that front. They did change the penalty structure, though, in 2021. It had been $300 a day, which is nothing for a hospital to pay. They moved it to be tied to beds so that a very large hospital could face up to a $2 million penalty per year, a significantly larger amount. So I think it's a matter of time. We know that the rates of compliance are growing, but they're not quite there yet.
Got it. Steve?
So before I ask my question, I'm going to do a public service announcement. So we something coming this April. First of all, we're going to have another one of these great chats, but we're going to overlap it with Innovation Week, which is actually the Design for Medical Devices, the device center that's at the University of Minnesota. They've been doing this now for over 20 years. And we're going to be having basically an interview. Tom and I will be interviewing some folks that are coming from the Netherlands, talking about their medical innovation and startup journeys along the way. So we're really excited to doing that. We're going to be featuring Jasper Van Vert and his colleague from 2 different startup firms and from the Netherlands. So Gene, I guess one thing there's 2 questions I want to get at. One of them is really kind of for the groups that's here, just to let people know how hard it is to get this data, because it's not like it falls off the trees. I mean, so you worked with the team at Minnesota. Just give us a sense of just what it's like to actually try to harvest this data, work with the information, to be able to turn it into something useful for an article or summary for even the press.
Yeah. So I think the first order questions that we've been focused on so far with the hospital data has been compliance. So basically that means going out to the website of each hospital, downloading the files, opening the files, scanning them to see what is there in terms of, did they produce the 5 standardized charges? Do they have the consumer price shopping tool? Being able to actually use the data itself is a much bigger task because in the rule, the CMS was not particularly prescriptive around the format that the hospitals had to use for the data. So it's been very difficult. And this is really where we have seen a niche industry evolve. Turquoise Health being one example of a data technology firm that has moved into this space and has multiple programmers working full time to try to get these data cleaned up and read in and put into a structure that will make them usable by others and by themselves, of course, for their own business purposes.
Yeah, I guess the one thing I want to ask you, so when you guys got to this earlier than most others, I know some researchers, and particularly one I know fairly well, Guy Bai at Hopkins, has just made like a cottage industry of putting this stuff out by specialty. Is there stuff as you started to look at it that surprised you that you just didn't expect to see?
I think people have been, in the kind of the early work that's really looking at the actual amount of variation. I think, it's not overly surprising. I think there's been some earlier research to kind of document the magnitude of variation. I think, this is a treasure trove though, because now it's so much broader in terms of the scale that we can look nationally,
Right.
where before we were constrained to kind of an insurer or a set of insurers through one of the data consortia. So I do think that there are important questions that can be asked. I think that, I think we've only begun to scratch the surface, and, I would expect in the next year or two, we'll continue to see quite a bit more written on this topic.
So I know with the insurer rule data, I mean, that's coming out monthly. Actually, that's one thing I pressed for very heavily when I was in the White House. So what's the frequency of this data that's coming out on the hospital rule?
I believe it's annual.
Okay.
It's annual. And
Okay.
and again, since we still have half of the hospitals that aren't fully compliant yet, at least by some of our estimates and others, that's part of the challenge of this, is what does compliance really mean? It takes a lot of effort to actually comb through a given file to be able to understand what's complete or not. So being able to measure that is can be a little bit challenging. So, the estimates do range basically between half and maybe 2/3 of US hospitals at this point have produced the machine readable data in particular.
And I guess I'm sort of curious, like I mean, as we know that, not all hospitals many hospitals are not independent at all anymore. There's many of them are
Mhm.
part of a chain.
Yep.
I mean, how does that work? Do you see that, like, if one of them, if they're part of a network, is the whole network showing up cross
Yeah.
country, or okay, how does that?
Yeah, so I've also done been busy on this front. Been also doing some qualitative work with folks from Virginia Commonwealth University and Ohio State University. We did a qualitative study. We actually interviewed hospital leaders across the country to understand their strategic responses to this new regulation. And we quickly learned that the vast majority of hospitals that are system affiliated, those decisions are made at the system. So they weren't necessarily hospital by hospital, which of course means that they had probably more resources to be able to leverage to create a more unified response. Still means that there's some challenges in communicating across, particularly for large systems, but we do know that it is generally a system response for a given hospital organization.
Yeah, I mean, that would probably make sense, because I mean, just in terms of a budget model, the penalties are going to go system level too, particularly if they're at the bed. So that makes, so usually when you think about hospital systems, there's for profit, there's not for profit. I mean, obviously government's out of there. I mean, do you see?
Although the government still has to comply, Steve. So,
Really?
yep, it's almost all hospitals. Yep.
I mean, the VA has to comply?
Well, the VA might mean maybe one that's kind of excluded, but other types of county hospitals and such.
Okay, county hospitals. Okay,
Yeah.
okay, so that's interesting. Yeah,
And critical access hospitals too. I mean, we know that, in our new work that we've been doing, we were looking at kind of changes over time in moving toward compliance. And, we clearly saw that, independents and smaller hospitals were a little bit slower to respond, but they're catching up at this point. Another really interesting thing that we have seen in the literature is the role that electronic health records have played, particularly Epic. We know in talking to hospital leaders that, particularly for the consumer shoppable side of the rule, that some of the IT EMRs have been able to build some of that capability in to make that easier. And so we know that there's some interactions there too.
Wow, that's not bad. But do you see, by class of hospital, now that government or county hospitals in there, do you see that any one of them is like doing better or worse proportionally of their, given the base of them, than others?
Not as much. I mean, obviously, intuition would kind of suspect that maybe for-profits would be less likely to comply, but we don't actually see a very large differential there. So, I think when we talk to hospital leaders, it had a lot to do, interestingly, with kind of values and kind of the role that they thought consumerism played. And also they often highlighted the issue of their market position. So did they think that disclosing this information was going to hurt them? How close in proximity was it to a negotiation with a big payer? lots of factors like that that were being weighed as they were making decisions. But for the most part, I think they wanted to comply, and it was a matter of having the resources and the bandwidth to stand up the response in a timely way.
So I've got one more question. I'm going to give you, Tom, fair notice. I'm going to throw back to you. So one area I've been doing a little bit of research on kind of quietly, haven't published yet, is more on site neutral payment types of stuff as it applies maybe on the commercial side, not so much the commercial insurance, I should say, not so much Medicare. So to that, have you benchmarked some of these things to Medicare prices just to see how far off they are? Because because we always tell the stories about commercial will pay here, and then Medicare will be at 65%, and Medicaid will be at 40%. Did you get a chance to test that? So
we haven't tested that yet, but I will say that ironically, in my teaching, the private purchasers course in school public health, I stumbled across the SAGE transparency tool that the Employer Forum of Indiana has stood up with Chris Whaley and Rand. That turns out to be a pretty interesting resource that does, in fact, look at commercial relative to Medicare ratios to be able to understand at a market level and a system level, hospital system level, and hospital facility level, what those different, what that variation looks like benchmarked against Medicare. So that's a useful public resource that's already out there that I think they will probably be leveraging what's coming out off of the price transparency tool to feed that in the future.
Yeah, that makes good sense. Tom.
So let's talk a little bit about the individual. So far, we've been talking about payers and providers appropriately. Those are the two big players, right? But if we take this a little bit into the future, maybe into the future, as we all know, deductibles have been going up. So even if insurance is my main negotiator for something, I still have to pay, especially in the early parts of the year, and a significant part of that. And wouldn't it be nice if I knew who the high quality, low cost provider was in my area so I could pay a lower portion? Ideally, I'll speak just for me, but maybe for the audience, ideally, wouldn't it be nice if we had a hotels.com where I just put in what I need, what price range I'm looking at, when I need it, and then filter it by quality stars kinds of. Do we ever get to that?
Oh, that would be nice to have, wouldn't it? No, I think we are heading in that direction. I think that we now have the infrastructure from the regulation, the data infrastructure to be able to feed that type of tool. And health plans, of course, are also going to be responsible for standing up consumer-friendly tools as well. You're exactly right that health insurance, consumers have increasing financial exposure with rising deductibles. I think the most recent estimate I saw was that an average family deductible for an employer-based plan in Minnesota is now over $4,000 a year. Yeah. That's a lot. And there's a fair amount of healthcare that you can actually shop for. So we need to be able to figure out how to make it easy for consumers. I mean, the literature so far does not suggest that consumers, they like the concept, they like the idea of having a tool, of having that ability to search. But when push comes to shove, only about 10 to 15% of people actually use price tools. So we have a gap there that needs to be bridged. We need to figure out how to do that. We know that there are some innovative health plans out there that are working to figure out ways to put everything together so that that information is sitting on your smartphone and it's, understandable by consumers. Consumers don't use medical jargon. It has to be translated to layperson language, and really thinking through, how do you make it easy? How do you make it easy? And how do you help consumers to think about these decisions differently? Because we've never really fully overcome that barrier of, there's a lot of money here on the line. It might make sense for you to shop because you might save thousands of dollars.
Yeah, let me just follow one question on that with Tom, because I'm trying to think about this whole notion of shopping and buying and getting consumer engagement, and the only analogy I can think back to in terms of getting to that, if you will, the hotels.com or kayak.com or some other thing, and I've used the analogy a lot myself in Expedia, whatever it will be, is that if you think about the first time that consumers got to shop an opaque market that they were interested in my opinion, was Prodigy. I don't know, and then maybe Tom, you might remember Prodigy. I'm not sure whether Gene, you remember it. I mean, so so Prodigy was a software system that came out in the late 80s that was DOS based, use your dial-up modem, and it basically it was like it was totally graphical interface, very crudely done, okay? Because it basically presumed it was a world before Windows even, but it basically had its own interface associated with it. But the one thing that it was sort of cool about it, it had a bunch of stuff that was sort of garbage, but was they linked to American Airlines Easy Saver system. And so it's something I used to teach in my e-commerce class, where like, just as a complete externality, unintended, American Airlines from the 60s on created a pricing system for all the other airlines, so that in case you missed your flight in the era of regulated air prices, you would know what the other price would be for that airline. And they were all, since they're all regulated, it didn't really matter that much anyway, so there wasn't much competition. Yeah. So that system existed, right? Reagan, well, originally Carter, but then to Reagan, deregulation of air prices, and so this thing still exists, but it's just out there in the wind. And then Prodigy made it available before Travelocity and everything else came along. So when I used it, I couldn't buy anything. All I could see was like, oh crap, if I can go to, I guess there was Delta Airlines or even Northwest, it's like I can go buy stuff, and at least I know it's going to be cheaper there. And that's kind of where we are now. Like, you do know pretty definitively, like, I want to go to Albuquerque. That's it's not like you need a CPT4 code to figure that out. Yeah. But the one thing that you can't do yet is say, boy, my shoulder really hurts, I want to get an MRI. Here's, to Tom's point, here's my 4 stars out of 5 stars above on France Avenue. Where can I go? And I see scheduling, and I have my credit card, even if it's an HSA card, and I punch the date and I punch the point and I got a schedule and we're good to go. And there's a feedback loop. We're not there. No. I mean, that's kind of what has to happen, I think, to really get the consumer to think about, like, why would they care?
And I think I think in addition, I absolutely agree with that. It's still piecemeal, right? It's still price data here, quality data maybe here, and then actually having to make the transaction. The other thing that I think we have to think about is the fact that your insurance benefit design is also dynamic. In the beginning of the year, up until your deductible, okay, then you're basically exposed fully to the cost, maybe. But then you have additional, co-insurance. So your out-of-pocket, so the price that you see posted may be very different than the price that you actually pay once it interacts with your benefit design during the year. So it's not easy. And we know health insurance literacy issues are a big deal in this country. It's not something we spend a lot of time in schools teaching. And so we have to really, there's a lot of work to be done to help people understand how to use their health insurance.
But does this give me hope? And I'll let Tom have the last word while we're on the record, because like you can imagine, just like some eyeglass places, like will reach out to you like in November, December, saying you're going to lose your FSA account. Mm-hmm. It's you can see a few orthopedic people going to kind of like, hey, is that before you lift that Christmas tree, check up on your shoulder, and you see how your deductible is doing.
Yeah, we'll mix AI in there too. That'll make it fun.
Exactly. Tom, close us out.
Officially. So I appreciate this. I guess as we bridge into the non-recorded part of this, I look at this as just Steve's brought this up before, just a gigantic amount of information that requires even more computer power to understand and analyze. And yet, as I look at that, it's kind of like the new big telescope that we launched, right? There's a lot of astronomers and a lot of academics that are really excited about all the data that's coming in. Is there a new era of data analysis that this is engendering within healthcare?
I actually think it has the potential to do that. I mean, I think there's a lot of excitement. If last summer's health economists research meeting is any indication of that, by the number of people who were chattering about different projects that they want to work on. It's, again, new source of data. I think that, those data are being created. I think it is a matter of figuring out who's going to process those data and the quality of the data, and then being able to look at things over time. Because I think cross-section is interesting, but fundamentally, we want to be able to understand how the availability of pricing information is going to change market competition and change behavior. So we need to be able to look at this over time consistently to see what's going to happen. And again, I think there are many uses for it, not the least of which is looking at antitrust policy and looking at competition.
Interesting.
Awesome. Well, that'll take us to the end of our off the record part. We have some questions that are coming in. Please stay on the line. We're going to have Jean answer them and read them off. So, thank you all for joining us. Thank you, Jean, for updating us on where we are with hospital price transparency. It's a great conversation. Stay tuned, and we hope to see you in April. Speak a little Dutch, maybe, at least better. Take care.